Thank you for allowing me to present this. It represents a lot of years of work uh, with my team at the Medical University of South Carolina and other collaborators around the world and the country. So anyway, today I want to talk about vitamin D status during pregnancy and its impact on birth outcomes, and also some data on how vitamin D can affect fertility. So the metabolism of vitamin D is quite involved. I don't expect you to appreciate this whole slide, but if you look at the top left, you'll see that vitamin D is the what we call the parent compound. It's a compound that is made in your skin in response to sunlight. You can also take it dietarily, although up to this point, the dietary amount that you can receive outside of supplementation with substantial supplements, oral supplements, really isn't enough. And by that, what I mean is the amount you get in if you drink milk or if you eat fish or any other food source. They're really not very suitable. They don't have much vitamin D in them. So we're dependent either on a lot of sun exposure or significant supplementation. And I'm talking about supplementation in the thousands of international units. So vitamin D goes into the bloodstream, where it goes into the liver, where a compound called 25-hydroxyvitamin D is formed. This is a form that, if you want to know if you have adequate vitamin D in your body, this is a form that is measured in the doctor's office. There's some confusion about this, because what happens is the 25-hydroxy is further metabolized into the active vitamin D form of 1,25-dihydroxyvitamin D. That's a hormonal form. It's one of the most potent steroid hormones known. It's the compound that causes all the actions in the body to become active through a vitamin D receptor. But it gives you almost no information if it's measured. And sometimes the physicians get confused and they measure this mistakenly. And actually that can lead to some issues, because I've had pregnant mothers call me when the physician has ordered the wrong compound. And during pregnancy, the active compound 125 is greatly elevated for reasons we don't fully understand, but it can be 4 or 5 times normal. So what happens is the physician orders that compound, the level comes back to the mother. The physician says, you have vitamin D toxicity. And of course, the mother goes crazy. And it's not at all the case. They're measuring the wrong thing. So you want to make sure that you measure 25-hydroxyvitamin D when you get this measurement, and make that clear with your physician. The next slide here is the classic function of vitamin D, which has been known forever, and that's vitamin D effect on bone metabolism. And if it's lacking early in life or in utero, you can end up with, as you can see here, bowed legs and referred to as rickets. This is very severe vitamin D deficiency. And with supplementation, as you can see on the right, it can be corrected. At least the skeletal part can be corrected, but we worry about other factors of vitamin D, which I'll talk about, which may or may not be corrected by supplementation. Here's another, it's called Tranniatabees. This is a severe vitamin D deficiency in utero in the mother. This was published several years ago by a group in Japan. And what happens here is that the skull, the fontanelles at the skull don't have sufficient vitamin D and calcium to close, and you end up with this condition called Tranniatabees. Now, once the child is born and they get sufficient vitamin D and calcium, this will normalize. But again, okay, to have this kind of vitamin D deficiency during pregnancy in utero is just totally unacceptable and never has to happen. So this slide is interesting because it goes way back to 1971. And what happened in 1971 is Dr. Haddad developed vitamin D research was really in its infant stages. They were just identifying these compounds. And 25-hydroxy vitamin D, the form that you want measured to figure out if you're vitamin D replete, we call it, had just been discovered, but they had no way of measuring it in blood. So Dr. Haddad and his colleague developed today we would call it rudimentary, but an accurate rudimentary measure to measure vitamin D. This was in St. Louis. And so what they did was they gathered a few groups, and as you can see here, they called normal volunteers biliary cirrhosis. And the reason they chose biliary cirrhosis is because it causes fat malabsorption. And fat malabsorption is an issue because vitamin D is, of course, a fat-soluble compound. So if they had fat-soluble inhibition of absorption in the intestine, it should show up with low vitamin D. And then they chose last one, they chose lifeguards, which in St. Louis in the middle of the summer. And then they measured the vitamin D content in these individuals as the last portion on the right of this slide. And you can see normal volunteers had an average of 27 nanograms per ml. It's in other words, it can be also referred as parts per billion. Biliary cirrhosis was substantially lower than what, quote, normal volunteers, and then lifeguards were substantially higher. Well, if this would have been interpreted back in 1971 in an appropriate manner, okay, the lifeguards would have been chosen as normal because those were individuals who had substantial sun exposure as humans came through evolutionary patterns, and that's the amount of vitamin D that would show up in a human if they had adequate sun exposure. Not 27. Normal volunteers in this case would be doctors, nurses, whoever, okay, they're inside, not getting a lot of sun exposure. And this created problems into the future because still today, they would look at this and still say, well, 27 nanograms would be adequate amount of vitamin D for normal bodily functions, and it's simply not the case. So you can go back to this slide and see the problems that were misinterpretation of data. And I'll say this is that back even in 1971, the government agencies were recommending that a normal vitamin D intake would be 400 international units per day. Well, 400 international units per day would roughly give you 27 nanograms per ml. But if you wanted to get to 64 nanograms, you would have to ingest 4,000 to 5,000 units of vitamin D per day. And the governing agencies simply couldn't come to grips with that and say, well, that's actually what you need. And that's still a problem today. And one of the problems we still face is that the amount of vitamin D that we're recommending to get to those levels are seen as levels too high, but we don't see it that way. And we come back to the fact is how toxic is vitamin D. See, that's the whole issue. Why they didn't want these levels of vitamin D ingested that were really necessary, and it was due to bad science. And if you look at the first one here, the guidelines in 1997, they said that vitamin D intakes in humans above 2,000 international units a day could be potentially toxic. And that was based on some really bad science, as recognized today. And that's ironic because in a human who gets substantial sun exposure on a given day can release up to 20,000 units of vitamin D into their bloodstream within 24 hours. So it's hard to see, and it's inaccurate that 2,000 units, which is 1/10 of what you can make naturally, could have any possibility of being toxic. And then I'll come down to this statement was grossly narrow as impediment to the health of humans. And I can tell you, if you go back to our initial pregnancy studies, which we started in the early 2000s, and we had to take these studies through the FDA was still stuck on this 2,000 unit number. And we knew that wouldn't even begin to get to the levels we needed to see. And so we had to submit what we call an IND, which is a drug application to study this. And it took months for the FDA to allow us to initiate our studies where we could give pregnant women 4,000 units a day. Later on in 2010, the Institute of Medicine, now called the National Academy of Sciences, arbitrarily set the upper intake, safe intake, at 4,000 units a day, which was better than before, but still not great. The truth is, intakes up to 10,000 units a day are totally safe. And you will not reach toxicity taking levels that high. And again, I'll bring it back to the fact that humans can make twice that much on a given sun exposure day. And here we are with that position from the Institute of Medicine. They said the optimal circulating levels are 20 nanograms per ml. They also said that levels of 50 nanograms are potentially harmful. This is all ridiculously wrong, okay? Normal humans, as I went back to that first slide, who have sun exposure are substantially higher than 50 nanograms per ml in nature. So there's no, I mean, it's just absurd to say that's potentially harmful. And this is, again, the humans evolving in nature for millennia have levels far exceeding that level. And to get to the point in the first one, about 20 nanograms per ml, all of that was based on skeletal integrity. And skeletal integrity really doesn't take that much vitamin D. You operate with two systems. One is called the endocrine system, which is basically the skeletal system. And then we operate with called the paracrine endocrine system, which is all the other things that we look at, which is immunity, cancer suppression. Those are separate systems, and those require much more vitamin D to be normal than the 20 nanograms. So this Institute of Medicine report really did a lot of damage to the studies that people wanted to do, because they would see this in the news and say, well, you really don't need that much vitamin D because the Institute of Medicine says it doesn't. But this was really archaic and should never be adhered to. So if we come to the public issue of vitamin D deficiency during pregnancy, it's evident that vitamin D deficient during pregnancy is a serious health issue that affects both mother and fetus. And as our studies, I'll show you how we went about doing this. There was a need to establish vitamin D requirements of pregnant women seen as vital in preventing vitamin D deficiency. And again, you come back to the Institute of Medicine, yet the recent Institute of Medicine, recent 2010, has not been updated. Only a slight increase in vitamin D's they increased it from 400 to 600 a day, which is essentially nothing. It's not near enough to meet the requirements of what a pregnant woman would need. So back in if we go back to 2000 and 2001, which is 20 years ago already, we decided at the medical university that we wanted to do a study where we would see how much vitamin D in a randomized controlled trial would actually would it take to increase vitamin D levels in a pregnant woman to levels that would be needed to have biological meaning. And also, it was largely a safety study because there was a lot of concern about how much vitamin D you could take and be safe about it. So we designed this study. We submitted it to the National Institutes of Health. They approved the study. And the study, back 20 years ago, this study was funded for about $4 to $5 million to carry on this study for 4 to 5 years that it took. That was then, okay, and people want to know why don't they do more randomized controlled trials? You see this all the time. Well, they didn't do a randomized trial for this, randomized trial for that, whatever, especially in the COVID era here. The truth of the matter is this, okay? Nobody's going to pay for it. Okay, nobody's going to pay for a randomized controlled trial that has any meaning of any size because there's no money to be made. That would be like me coming to Ovaterra and saying, I want to do this randomized trial the way that the medical community wants it to be done. And oh, by the way, to do that trial, I probably need about $50 to $100 million to do it the way they want it done. That's how they do drug trials. But they want nutrient trials run the same, and they know that they never will be because nobody will ever pay for them. So we have to run smaller trials like we did here, and even those today would never be funded. And so you come back to the standpoint is you can look at randomized controlled trial data or a lot of the observational trial data, which we do, to come to the conclusions that we have come to. Now, go back to our study here. We wanted to look at women. Women come in, they come in the first trimester where they're determined to be pregnant. We put them on, in this study, 402,000 or 4,000 international units per day. We monitored them through their pregnancy from the end of the first trimester through the last 2 trimesters, and we looked at everything under the sun for safety, because that's what basically what this was. And the last portion of the slide there, you can see that we were required to go to get an investigational drug number to study this, which was unheard of, to study a nutrient. This is what drug companies have to do to study whatever. Okay, recently it would have been the COVID vaccine or any other new drug. They have to go get an IND. They forced us to go do this to carry on our study of vitamin D, in fear that we were going to hurt somebody. Now, I can't go through the whole study because I simply don't have the time. But when we finished the study, we broke it down by groups, and we were interested in, although we didn't know this when we started, so because it was unknown, we had no idea that vitamin D would have an effect on birth outcomes. And so when we had this data analyzed, you can look on the right side, and you can see the larger numbers are listed in blue. Those are the significant p-values that lit up across groups in a randomized trial that had cesarean sections were decreased, complications of birth, which is preeclampsia, gestational diabetes, was decreased, and also comorbidities of pregnancy were decreased. And this was really a shocking development. And to be honest, nobody believed it. This was presented at a meeting back in 2009 at a vitamin D meeting, and I presented it, and I was virtually attacked. Is that, how could you present data like this? Why would you do studies like this? We all know that vitamin D is only significant for bones. And why? How could it be all these other things? And I said the data are the data. There were indications from observational studies that this might be true, but it was a randomized controlled trial that actually showed it to be true. So this was a remarkable finding. And again, it took up the higher group is 4,000 units a day, and to observe these effects we saw with decrease in birth complications from vitamin D. So the bottom line is the establishment, and especially the drug companies, don't like to see articles like that, because they try to develop drugs that would do that, and they don't want a generic compound such as vitamin D showing promise in making these things happen. And that's just not in pregnancy. That's in cancer prevention. It's in COVID outcome prevention. You name it. Okay. The drug companies are spending billions to try to come up with drugs, essentially, that vitamin D can mimic and actually have outcomes. And so you're attacked by the status quo in medicine, not to have this to muddy the waters. Okay, they don't really want this. So here was a study that was done a few years ago: vitamin D's supplementation in pregnancy, lactation, infant growth. It was published in New England Journal of Medicine, one of the top established medical journals. We always tried to get our information published in. And when you show, you can be sure that if you submitted an article that has positive effects on vitamin D on whatever it may be, cancer, pregnancy, they're not going to publish it. Okay, they're going to look at it, reject it for whatever reasons. But if you submit an article like this one by Dr. Roth, and what they did was they did a study similar to ours, except they used way lower amounts of vitamin D and started it much later in pregnancy. to look at the similar things that we did. Then they published this paper and saying, see, vitamin D is ineffective. And we wrote letters to the editor, which in New England Journal, which they actually published. And I said, these studies are not comparable. These guys used way less vitamin D and started them way later in pregnancy to come up with this negative information. And when the authors responded back, they basically gave no response back, because this piece had no relation to the data that we had done previously with higher levels of vitamin D started earlier in pregnancy. And again, why was this article negative? They supplemented an inadequate amount of vitamin D to the mother, and they waited too long into the pregnancy to begin supplementation. So if you wanted to ensure a trial would fail, this is how you would do it. And then you would publish it and say, see, vitamin D really doesn't have an effect. And that's exactly what happened. And again, it muddies the water. People say, well, see, we told you vitamin D was useless for this and vitamin D was useless for that. And but there's so much data to contradict that and to back up what we found more than 10 years ago. Here was a study that came out of India. This was in 2015. And what they did was they started vitamin D supplementation at 20 weeks, similar to what we did in our initial study. And then they looked at the incidence of complications of pregnancy. And as we found, the same data when they gave placebo versus vitamin D supplementation, which was several thousand units of data to these women in India. India has, by the way, a really big problem with vitamin D deficiency because of cultural issues and dress. And even though India has a lot of sunlight, there's a lot of cultural reasons that their levels of vitamin D are quite low. And you can see quite simply here that vitamin D supplementation, as we found, greatly decreased the complications of pregnancy in their population. This was another study that I was actually involved with. It was run out of Iran a few years back, and it was a very complicated study. It was a stratified randomized trial. I thought it was an incredible trial. And it was submitted to New England Journal, it was submitted to Lancet, it was submitted to British Medical Journal. None of them wanted anything to do with it. Ultimately, we published it in a good medical journal, a journal of endocrinology and metabolism, and the results were quite striking. And if you look, again, I can't go into this in great detail, but if you look at this outcome slide on 25 vitamin D and supplementation and how it affected birth outcomes. So the way you read this graph is you see towards the right where the arrows are, there's a line going down the middle. And if there's no effect, those arrows and that dot would be on the middle of those lines. Anything to the right would be a negative outcome, and anything on the left means things got better with vitamin D supplementation, and there was a positive outcome. Every single one of these outcomes, preeclampsia, gestational diabetes, preterm delivery, and complication of pregnancy outcomes, every one of them showed improvements in outcome, and a lot of improvements in outcome. So this clearly showed that vitamin D and the levels that they were giving, which was, again, several thousand international units of vitamin D per day, had profound positive impacts on complications of pregnancy. Well, let's look at preterm birth. This was data that came from our data set and also an organization called Grassroots Health. And what we did was we looked at gestational weeks at birth versus serum 25-hydroxy. Okay. And what this graph shows is when vitamin D levels get to be 40 or 50 nanograms per ml, which is the target level that we feel that pregnant women should be at. Okay. If you go down to here and you look at where the Institute of Medicine says, well, 20 nanograms, and you go up, you can see that is contributing to preterm birth, meaning this is gestational age at birth. So gestational age at birth does not normalize until you get up to about 40 nanograms per ml, and then it plateaus off. So this again shows a clear effect, positive effect on vitamin D at preventing preterm birth. I need to go back one slide. So another study we have here that was run at Harvard. This was another randomized trial. This was an enormous study, 3-site study, cost well over $10 million. And what we were looking at is the effect of vitamin D and prevention of asthma in infants. There was a lot of observational data to suggest this was true. But again, you want to look at a randomized trial to make sure that it's real. So I was involved in this study, and it went on for years, and in some aspects it's still going on. But anyway, this data was presented and ultimately published. It was called the VDART study. It's the Vitamin D Antenatal Asthma Reduction Trial was the full name of this. And the hypothesis from this trial was vitamin D supplementation in mothers during pregnancy would reduce the risk for asthma allergies and prevent the development of asthma allergies in the child. And the study, basically, women were started on 4,400 units of vitamin D from the time that they were found to be pregnant, which was about 12 to 14 weeks, pretty much through the first trimester, which was actually a weakness of this study, which I'll discuss. And we looked at the rates. This is Kaplan-Meier graph. And basically what this showed is that there was a reduction in asthma in women who were supplemented with higher levels of vitamin D, a reduction in asthma in their child at birth. And here's some further data. What this shows in this trial was that if women who started with low vitamin D and were given low vitamin D, they had a much higher rate of their child being born with asthma, as opposed to women who had high vitamin Ds and were given the high vitamin D supplementation at birth. So what it shows is if you go through the first trimester with low vitamin Ds, which in our study we couldn't prevent because we didn't see them in the first trimester, they'll be at higher risk, even if we supplement them with higher vitamin D levels as they go forth in their pregnancy. And the final publication was published in New England Journal. And the data at 6 years tended to be negative. And so of course you see in the media, vitamin D doesn't have any effect on the prevention of asthma. But there were many issues with this study, okay? Because we saw positive results if we looked at different ways of analyzing this data. But when you do randomized trials, they want you to spell out first what are your primary endpoints, and you're not allowed to go back and make any adjustments. You can only look at what you say we're going to look at. You can't go back and look at other things or introduce other variables, because they said that's a violation of your randomized trial. So anyway, first, okay, the first problem with the study is the compliance was poor in a minority population, and that greatly altered the final result. What do I mean by that? Well, a lot of the asthma takes place in the Black community because, and I should have mentioned this before, but if you have dark skin, you make a lot less vitamin D, and the levels in the African-American population are way lower all across the board than they are in Caucasians. And this presents an issue. And when the minority population have, and this is a problem across any drug studies, minority populations are leery of any drug study, and when you recruit them in, there's a chronic problem of poor compliance, meaning they're not doing what they're supposed to be doing and taking a drug. They will say, yes, I'm taking a drug, when in fact they're not. And when that happens, it just basically destroys the study. If we analyze the data in the study based on 25 levels, and the results become significant, but again, as I explained, you're not allowed to do this because in an intent to treat model, you're not allowed to alter your initial premise. Maternal vitamin D supplementation needs to be done pre-conception. And this is incredibly important, okay? When you're looking at vitamin D supplementation or women becoming pregnant, so much of this, of lung development, brain development, all of this is dictated largely in the first trimester. But when we do these studies, like we did, you don't have access to these women in the first trimester because they don't know they're pregnant. So to do an ideal study, you need to start vitamin D supplementation preconception. So when the mother becomes pregnant, there's not a deficiency during that first trimester when all these important processes are going on. Now, if you come back and you want to say, well, I want to do a preconception vitamin D study in a randomized controlled trial environment, financially, it's impossible to do. And we've looked at this, and it's just not going to happen. So you have to look at the observational data and data we have, and just come to the conclusion is it's really bad for women to become pregnant and not be vitamin D replete during that first trimester of pregnancy. And that means you have to start taking vitamin D when you think you want to become pregnant. Maternal vitamin D supplementation needs to increase to 6,000 IUs per day, because we know that in our population, even though we gave women 4,000, not all of them reached the levels that we wanted to see. So we've modified what pregnant women need to take to have a population in general come up to where they should be of vitamin D in their blood, and that would require an intake of about 6,000 IUs per day. And vitamin D supplementation needs to continue in the infant following birth. If you want to see the optimum, say the child is born. In our study, we didn't supplement past birth because that was a study design, but in truth, the infant needs to be continually on vitamin D, of course, following birth. Another thing in the VDART study, we looked at secondary, we looked at preeclampsia and preterm birth. And we're going to go through these because it's getting into the presentation. But if we look at this particular slide, it's just remarkable. And what this shows is, as you'll see at the bottom, a level of 40 nanograms of vitamin D in a pregnant woman's blood is a Perskett classifier of preeclampsia cases. If you look at the top of this graph, there were 70 in our population of about 800 patients. There were 73 cases of preeclampsia and 745 cases that did not develop it. Every single case that developed preeclampsia was less than 40 nanograms. So you could read this graph and say, you almost have perfect protection, okay? If women have 40 nanograms of vitamin D at birth when they conceive, okay? This is the levels that were measured in our first visit, which was in the first trimester, before we had any intervention into these women. And women who on their own were 40 nanograms, we did not see a single incidence of preeclampsia in these women. And again, if women took 6,000 units a day prior to pregnancy, that's where they will be when the critical time. Here was a new study that just came out. It was called Effective Intrapartum Vitamin D Levels on Labor Pain. And this is quite remarkable. And there's been a lot of work done on vitamin D and pain in general, chronic pain, but this was the first time anybody looked at it. And this is an observational trial. It's not a randomized trial. And again, we're never going to have a randomized trial for this type of thing. So you have to look at this observational data and make your own conclusions from it. But If you look at the labor pain scores on the vertical axis here, and on the x-axis, it's the level of vitamin D. You can see that as the level of vitamin D increases, the intensity of labor pain drastically decreases. And so this isn't surprising to me, because we've seen it in other pain studies not related to pregnancy. But again, look at the bottom. Look what the levels you need to attain. Look at 30 nanograms in the red, 40 nanograms in the blue. There's again, you come back to this 40 to 50 nanogram level where you need to be to have all these systems optimized during pregnancy and fertility. Just a quick graph of I mentioned vitamin D has effect on many other things than skeletal outcomes. And these are some of the diseases that we've seen that have intimate reactions with vitamin D deficiency, lupus, connective tissue disease, of course, immune system disease. You've probably heard a lot about this during the COVID epidemic, pandemic, with amount of vitamin D you should have. You need substantial amounts of vitamin D to make sure your immune system is functioning properly. It's involved in decreased inflammation, decreased autoimmune disease, decreased infections, and so forth. Okay. And so vitamin D, again, come back to this graph, has profound effects on many different non-skeletal functions within the human body. This was another vitamin D study that was performed along the same lines of our asthma study. And things are a little different. They used less vitamin D. They intervened later. But what this study did demonstrate was that vitamin D provided increased skeletal mineralization in children up to age 6 years of age, which is important because, as I showed you in the earlier slides, it's clear that vitamin D has effects of skeletal formation in utero. And this particular study said that carries through up to 6 years of age just by adequate amounts of vitamin D given during pregnancy. And a few things about vitamin D and fertility. None of these studies have ever been done in randomized trial form. They're all observational studies. Some of them I've been involved with. But vitamin D and fertility in the female, there's clear vitamin D has a regulation of sex hormone steroidogenesis, estrogen. It decreases polycystic ovary syndrome. It has a positive effect on ovulatory dysfunction. And it also seems to have a positive effect on a decrease in endometriosis, all of which are related to fertility. And vitamin D in the male, not as much has been looked at, but it's interesting that some of the most active vitamin D receptor functions are in the male testes and is related to spermatogenesis. So although there's not as much in the male, clearly it still has an important function. So the conclusions, vitamin D intakes up to 10,000 IUs and circulating levels up to 100 nanograms, which is physiologic in sun-replete individuals, are normal in human physiology. Do not treat vitamin D as a poison. Vitamin D supplementations at levels we tested have never resulted in a single adverse event in pregnancy. And I want to come back to this, okay? When we did our studies, our randomized trials, we had data and safety monitoring committees. They were looking at everything because, again, the FDA thought, well, you might be doing some harm to these patients. And we had boards. We looked at, and this board looked at everything, and I've been involved in a lot of this. Never, not one time in all the studies, and these are thousands of patients that we've looked at, have we ever seen an adverse event related to vitamin D supplementation. And yet we still hear this, and we're still looking for the first instance. It's absolutely ridiculous. Vitamin D supplementation during pregnancy is vital in the protection and enhancement of neonatal skeletal development, as well as in the prevention of birth complications, including preterm birth, preeclampsia, and gestational diabetes. Prenatal vitamin D also appears effective at enhancing neonatal lung development and preventing the development of childhood asthma and wheeze. And if you go back and look at the known effects of vitamin D on lung function in experimental animals, this is quite clear that it's true. Now, one last thing here. This is really important because to get the Food and Drug Administration to change a label claim, okay, and what I mean by that is, say you have vitamin D or vitamin C or vitamin E or whatever you have, and you list on your supplement that vitamin D will prevent cancer, or vitamin D will enhance immune function. You can't say those things. But the FDA will come to you and shut you down and make you take that label claim off, and you'll probably be fined. Okay. Up to this point, to 2 years ago, the only label claim that could be made for vitamin D on supplements was that vitamin D had a positive effect on skeletal outcomes. We've known that for, like 60 years longer, okay? But 2 years ago, based on a lot of the data that I've shown you here, okay, the FDA allowed a label change on vitamin D supplements to state that vitamin D may aid in the prevention of birth complications during pregnancy. That was a huge admission by the government that vitamin D is very important in these functions, or they would never allow this label claim to be made. Now, what they didn't do is recommend a level of intake. Say, we recommend that the level of intake be 4,000 or 6,000 or whatever. They didn't make that. Basically, they deferred to the physicians and said, if you could take these supplements and you need to have consult with your physicians and have blood levels tested to see where your blood levels are. So while they admitted that vitamin D has an effect on here, they punted on amount of vitamin D to be taken, and that's probably not a bad thing because vitamin D intake in a given individual can result in quite different blood levels in circulating. So anyway, thank you for your time.